Are you a woman that struggles with addiction or alcoholism, or do you know of a woman in your life? Maybe it's a dear friend of yours that struggles with addiction or alcoholism, and you feel like there's no resources there. They want to be clean, they want to be sober, but the help isn't there. The assistance isn't there, and there is no clear path for their recovery. In this episode, we have a researcher on, Heather, that really discusses the ins and outs of women, in particular pregnant women, and really the uphill battle that they have to face on a daily basis to recover from their addictions and their alcoholism. It's a very insightful episode. Ben and I walked away with a lot of knowledge that we didn't have before, and I know you will too. Enjoy the show. Here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
What's happening, everyone?
And we also have Heather. Heather, how are you?
Great. Thank you so much for having me.
First things first, thank you for tuning in on the podcast app, whichever one that you choose to use. And thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you can always reach us. info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message, right, friends?
Yes, sir.
Hello, Heather.
Good morning.
It's Monday morning here in sunny South Florida. It is approximately 10:04 a.m. And Heather has come on the podcast. I think this is going to be a fun one. Ben, kick us off. Tell us how you guys made the introduction.
So Heather and I, we actually were introduced to each other through Stoked on Life. And anyone that's been listening to our podcast, we had both Allison and David on in the past. But essentially, Stoked on Life is... Let's just say it like this. At our center at Rock, we do experiential therapy. One of those things that I was trying to implement on my own was surfing, because I grew up surfing down here, and I would haul the boards down to the beach, all that stuff. Well, then I came across Stoked on Life. I was introduced to them through Stephanie Matthews, a.k.a. now Stephanie Eddowes, who's been in the field forever. She made that introduction, but Stoked on Life essentially took the reins for me on the whole surfing thing, which has been awesome. But they're a 501c3 nonprofit that essentially, not just substance abuse, but all mental health, if you will. Bringing in, introducing surf therapy, Blue Mind Theory. Is it theory?
Yeah, that's right. It's Blue Mind Theory, and it's really, some of our aquatic associates are excellent surfers, as have the history like you, but also it's aquatic.
Mm-hmm.
So stand-up paddleboard, snorkeling, just floating. And that Blue Mind Theory that you're talking about is in, on, or above water for 23 minutes a day really can decrease stress and create a calmness and help cope with anxiety.
Yeah, so also the writer, if you will,
yes,
of Blue Mind Theory, Dr. Nichols. Do I have that right?
That's correct.
He came on the podcast, what was that, a year ago probably?
I think so, but
something around
I don't
there.
know.
But he was actually on as well.
Oh, that's wonderful.
At one point,
it was Wallace, right?
Dr. Wallace Nichols.
Yeah.
And
he's passed since.
He's passed, but we had the privilege of co-authoring the curriculum we offer.
Mm-hmm.
So that Rock Recovery is really involved with. So it's 8 modules. Some of the modules is connection, going with the flow. The last module is service, where they're actually do a beach cleanup and connect that to early recovery, and how everything is connected, the water, recovery, but like you said, it's also co-occurring. So treating mental health, treating depression, anxiety, because my experience is that it's always co-occurring,
mm-hmm.
right? Absolutely.
It's what comes first.
Exactly.
The mental health or the substance use. And I've never had the answer, my best answer because we get that question quite a bit. I don't understand why my son or daughter is doing this, or why, they have severe, I think that they're using the drugs to tamper down the anxiety, the depression, the this, the that. And it's like, well, when was the last time they were even clean for 60 or 90 days? It's really hard to determine what's causing what. Is the substance use causing these symptoms, or are these symptoms flaring up the substance use?
Right. And then, so knowing that you treat both
right
simultaneously,
yeah.
right? because that's what's going to support somebody in their early recovery, addressing the depression, addressing the anxiety, simultaneously trying to create a sober lifestyle,
Yeah.
right? And what is it like to be without using?
Yeah, and we chatted a little bit before we hit record. There's a couple directions I feel like we can go with this. And in a generic sense, I'll just say that Heather also does a lot of research. I would consider you a researcher. Is that is that how I title
It's one
it?
of my hats. It's one of
Yeah.
my hats.
So with that being said, and we'll dive more into detail throughout the episode, I'm sure. But I touched on the experiential therapy part, and I thought Tom was going somewhere else with it when he brought it up. When parents ask, like, why is my kid doing this? Like,
Right.
one of the things that we get calls about a lot of the times is like, for instance, more it's with spouses. Like, oh, my wife's down there just doing surf groups and adventures and experiential stuff. They're on vacation. But we met again through Stoked on Life, and now you're basically heading that up as far as and heading up the research part of the Blue Mind theory for them, all that stuff. But one of the things that I kind of want to touch on, since we're bringing it up, is like, for us, the value in the experiential is built the ability to build community. Like, people tend to be more open, more vulnerable
Absolutely.
when we're out and about. Like, when we're we have like the classroom setting here at Rock, just like any treatment center. Our clients are downstairs right now with Rabbi Mark, going through their 3-hour group this morning. And we have phenomenal facilitators here, but there's something about when they're out and about doing something,
Absolutely.
whether it involves water or some other activity,
Mhm.
their level of authenticity, getting vulnerable, it's like their guard is down.
Absolutely.
And if you want to touch on
I'd
that,
love to. I
yeah.
think that's I think that's such an important point, because when you mention surf therapy or you're out on the beach, people just assume what you said, right? Oh, they're just having fun, they're having vacation. But there's this element of being in nature, being by the water, that not only naturally increases your happy chemicals like oxytocin, right? And dopamine, but you're with other people and it feels safe. So that's why you're able to have this connection very quickly. Where if you were in more of a group setting, it takes a while to be able to develop that trust. And so, the major principle of trauma informed is establishing safety and trust.
Mm-hmm.
Being by the ocean actually creates that almost immediately. And when you're, every single group, you have to go on a mindfulness walk and find some intentional piece that resonates with you. And so you come back with a shell or a driftwood, and that is actually a medium for me to start sharing and to be comfortable in sharing and being vulnerable of what you're talking about, Ben, because I might be a person that hates groups, doesn't want to share my personal with anyone else, but having this shell or driftwood and hearing other people, it's incredible. As my background is a clinician, and just seeing, you move in so much quicker in terms of the growth and being open and being vulnerable. And just in that 90-minute, you can see the baseline of where you're at in the Blue Mind health.
Mm-hmm.
You might be in the low red or the high red, depressed or highly anxious. And just within 90 minutes, they come back and they're feeling more in the Blue Mind of that calm and that peaceful and being able to be open. It's really incredible.
Yeah, there's a couple things where I'll throw this out there, like, from a clinician's perspective, in my opinion, if you're a good clinician, like, I do this intentionally. Like, I'll have a client, we'll catch a couple waves or something, but then we'll like put the board aside and we'll just be kind of floating around in the water next to each other and just having a normal conversation. But then they'll start dropping tidbits, and I put those in my back pocket, and I'll use them like a week later at the center.
Perfect.
Like, it's kind of like they don't realize I'm going back door to get some of the feedback that they're going to need to hear the truth about themselves.
Yeah, you're identifying their language and putting it in your back pocket.
Exactly.
Which is so critical because that's that kind of cultural sensitivity to an individual.
Yeah, trust is so important in this process.
Absolutely.
If someone comes into treatment and they don't trust the people they're with, game over.
It's
They're
so
not going to get
critical.
anything out of it.
So I'm so thankful that RAC Recovery is engaging this because, we're studying it and saying scientifically we know that this increases psychological well-being or decreases cravings. But, I can tell you anecdotally that the patients, the clients it's helping in their healing in amazing ways. Having being part of this curriculum, these 8 modules, the clinical part on the beach is incredible.
The other thing that I like to do is like in real time, and I do this more intentionally when we do like the workouts here in our gym at the center. Like I'll get a client and in the beginning I'll just nonchalantly ask them, "How you doing today?" They're like, "Oh, I have no energy. I'm down. I woke up depressed this morning." And I'll get them to work out and I'll approach them at the end of the workout and say, "Remember at the beginning of the workout, you're telling me you're depressed, your energy's down? Like, how's your energy now?" Like, you know what? I'm a little more awake. And getting them to realize that stepping into action.
Yes.
And because you mentioned all the oxytocin release, the endorphins, all that stuff.
Absolutely.
I think one of the biggest things, as I'm hearing you guys speak on this, the 2 words that came to mind for me was pattern interrupt. And why I think that is because oftentimes when we have people come into treatment, we're not their first rodeo. They've been to treatment, maybe that's their first time in treatment, but the vast majority has at least been to 1, potentially 2, maybe even 20 treatment centers prior to. They're used to going into a group room, sitting down in front of a therapist that probably doesn't want to be there, with a group of peers that maybe they don't want to be there, processing their feelings, peeing in a cup, eating some food, and going home. It's a pattern. It's on repeat. You know,
made that sound terrible, Tom.
Well, it's the truth. I mean, it's the reality of it.
Yeah, it is.
Most treatment centers are structured that way.
Right.
When you get them outside of the group room and you get them onto the beach and you have them go and find something, a piece of driftwood or a shell or something, it's a pattern interrupt in the sense that what? Like, I don't understand this, but I'll do it. And it's something that kind of goes a little bit against the grain. Same with why I'm a huge fan of like art therapy. It's a pattern interrupt. It's something different. Another, we'll go play basketball, do something, volleyball, pattern interrupt. Like, hey, this isn't all just group. Now we're going to tie in a clinical element, but it's in a different kind of form. So
you got to come from every end because we're also big time 12-step based here. So it's like, you can't just hammer somebody with 12 steps. 12 steps is my love language, but I know it's not everybody else's. Right. And we have to be aware of that from our position.
Multiple pathways to healing and recovery, right? Because if it was a one-size-fits-all, we wouldn't have the National Survey of Drug Use and Health saying every year that, 50 million have alcohol or substance use disorder. Of that amount, only 10% access treatment. I mean, that is abysmal, right? It's unacceptable. How can we think about treatment differently? So I'm glad you mentioned that, Tom.
So let's dive into a little bit of your the educational side of it, the researcher side of it. Because I say Ben and I are just 2 bozos on the bus, and we have the luxury of sitting in front of 2 microphones, and people will listen to us, generally speaking. But you have, let's just put it, street cred. Well, no, it wouldn't be street cred. It would be book cred. You've dove into the research.
Book learning.
So take us kind of on that journey for you. And the one thing you have like a big part of your career was specifically towards women.
Yes.
Take us through that.
Sure. So when I was a little girl, my mother had lupus, chronic disease, painful, the systemic kind. And in the 80s, it was treated with morphine. So my mother developed a very severe opioid use disorder before it was even a disorder. And so kind of, living with someone that had an opioid use disorder, what was that like? I really wanted to make my mission to help families that have, in some sort of way, alcohol or substance use disorder, because it's to me, it's a family disease, and everyone plays a part and a role. And so I finished my undergrad in psychology at Boston College, stayed on and got my master's in clinical social work, and started my career in pediatrics. And doing that and working with families impacted not only with alcohol and substance use, but disease and coping with that. And when I began my career, I had this incredible implicit bias that anybody that had an alcohol or substance use disorder should not parent. And I can say now, and for the last 15 years, nationally, I'm probably the strongest advocate of supporting families and helping parents, fathers, and mothers find recovery and stay connected with their children. But that's a journey, right? And we, working on our own, we all have implicit biases. And I teach my graduate students reflexive practice. And when you're working with other people, what do you bring into the therapy room? So I worked for 21 years at a Brown University-based birthing hospital. And at the turn of the century, and how I went from pediatrics to women's health, I started having kids. And it was a lot for me to work with children that were being abused and also becoming a parent. I wasn't able to separate that really well. So I said, I'm going to jump into women's health. But it was a birthing hospital, so it was the beginning of families. So I kind of still stayed in the family realm. It was just at that very strategic part when it begins. And there was just patient after patient that were dependent on opioids. And when you have your master's and you're in a healthcare system, you're the clinical social worker. But when you have your PhD, then they'll listen. So I had met this one patient. She delivered in Massachusetts. She had been on methadone. The baby was in the NICU, the neonatal intensive care unit, for a long time. And she didn't want to go through that again because the baby had neonatal abstinence syndrome. She had some separation from the infant. So subsequently, when she became pregnant again, she said, I don't ever want to go through that again. She was my patient. I was in Rhode Island, in Providence. So I really advocated. She wanted to taper off the methadone. And our OB-GYN said, you can't do that. You're going to have a stillbirth. You have to stay on the methadone. If you don't, we're going to call DCF, Child Protective Services. So here you have this person that has no self-determination, no voice or choice in her medical care. And she said, I'm going to go to Massachusetts because they will let me taper. So she left, and I asked her, could you reach out to me after you deliver? I just want to know how you're doing. And so we did. We communicated professionally, and she delivered a baby. She wasn't on methadone. The baby wasn't in the NICU. Her and the baby were doing really well. They weren't separated. And I said, she had a lot of supports. She was really involved with Alcoholics Anonymous and NA, and she had I think she had a sponsor. And I said, how was your experience in the hospital? And she said, everything was great, but a nurse came up to me postpartum in the postpartum floor and looked at my medical chart and said, I can't believe that you were on methadone during your first and second trimester. And that actually propelled me to go back and get my PhD. Because when you have your MSW and you're an LCSW, that's the terminal degree, right? You don't need to go further in your education. But I said, there's no research, there's no advocacy, there's no support. So she was, excuse my language, damned if you do, damned if I don't. So in Rhode Island, she was getting penalized for getting off the methadone. In Massachusetts, she was getting penalized or stigmatized for being on methadone at all. And so I went back at that point because she was one of hundreds, Tom, of women that were experiencing this. And really the initiation was wisdom teeth removal. Dentists prescribe Vicodin to adolescents, 18 and 19-year-olds. And, you talked about like what comes first, the mental health or the substance use. Women in particular, up to 85% have had childhood sexual abuse. And I only know that because I've worked primarily with women in my career, but thinking about that, and you take opioids for the first time, and you have epigenetics, you have all these variables, and all of a sudden you feel like you can be in a social situation and not feel anxious, or the pain is taken away, the emotional or psychological pain. And that is just the beginning of something. And then all of a sudden it starts taking over your life. And then subsequently you become pregnant. And I always tell people, pregnancy never supersedes an alcohol or substance use disorder. Never. I've worked in this field for 3 decades, and I've never met a woman that decides, oh, I want to start drinking or using substances now that I'm pregnant. Never, ever, ever, ever.
Right.
Pregnancy is just a bump, a very small bump in somebody's journey, right? But it's the strategic opportunity to be able to help someone, because they do want to consider, because they're thinking of a different way of being, because they're thinking of another life.
For our listeners that maybe don't know what methadone is medically assisted treatment. I'm guessing, I don't know the exact details, but this young lady probably was a opioid addict, and then a form of treatment is getting
Yes.
on methadone. We've now moved more towards Suboxone. You still see methadone around, don't get me wrong, but methadone it's still an opioid, but it has a really long half-life. And in theory, there's not supposed to be the highs and lows.
Correct.
It's just a very steady. I have a history myself on methadone and Suboxone, so I'm very familiar with it. And I'll say this: the thing about it is that methadone, in my experience, is the most physically addictive opioid I've ever been on in my life. And that's the irony in the whole thing. That's a topic for another episode, but literally, I was more physically addicted to methadone than I ever was any other opiate. But because it doesn't have those highs and lows, and you're just constantly at a certain state,
Right.
because of the long half-life. And I'm curious too, I've never actually researched this, but as far as them not wanting her to get off of methadone,
Where does that come from?
yeah, is that because the withdrawal? I know that, a newborn going through withdrawal probably has dire consequences, but with opioids, you don't really hear about it like you do with meth, with alcohol, with crack, where there's serious, what's the word I'm looking for?
Adverse experience.
Opioids, you don't really hear too much.
Opioids, incredibly, incredibly sick.
Yeah.
I haven't personally experienced, but it feels like, COVID on steroids, right? Like a extremely bad flu. And that if you use opioids, that the pain will subside.
Mm-hmm.
So, at that point, it's not using to get high, it's using so you're not sick anymore. And so, Tom, you asked okay, how did you get into research? That kind of propelled me. But I really wanted to understand, what are the options? What is the decision-making process? What do women do that have an opioid use disorder and become pregnant? And still, there's these options, right, of tapering safely under physicians' I don't like to use their surveillance, but guidance, methadone or buprenorphine, right? And the studies recommend that buprenorphine is really the best, because the infants have less of a hospital stay and less pharmacological intervention. But so I went and did my PhD and interviewed 20 women in the New England region. And I'll never forget, I kind of had this bias of everyone should just taper. Everyone should just taper, right? And then one of the patients, shared with me, if it wasn't for methadone, I wouldn't be here. I would be dead, because I tried tapering. I tried buprenorphine, and that really taught me, and I published on this, of the importance of shared decision making. And that's actually a SAMHSA-based, evidence-based practice, which basically, it's very similar to motivational interviewing. where I say, okay, Ben, here are your options. Tell me what's going on in your life right now. What's feasible? What's possible? What does your insurance cover? And if you want this choice, is it your choice or is it under coercion? Is a partner or is a parent kind of persuading you to do this choice? And if that's the case, it's not going to be successful. You can listen to these other voices, but I really want to know what's best for you right this moment. I'm not talking about a year from now. I'm not talking about 5 years from now, but like right now, what's going to keep you alive and okay?
Well, the patient, the client has to buy into the plan
Mhm.
is what it comes down to. I have personal experience that with I like what you just talked about, like the coercion, so to speak. Specifically, I had an episode where when I was on the methadone program, there was a day where I had just had it. Like I was emotionally, spiritually broken. And I remember I showed up to the methadone clinic and the lady put my cup in the window and I had been like ruminating on it for probably a couple weeks at that point. And I ended up taking the cup and I just threw it in the garbage. And the lady looks at me. She's like, "You can't do that." She like yelled at me.
Right.
I'm like, "I'm done with this stuff." And like, I ended up getting really sick
Yes.
48 hours later. But point is, it's like they sent me to the therapist's office after I threw that. And the therapist's like, "What's up?" And I'm like, I don't want to be on this stuff. And they're like, "Oh, you need to stay on it." Like, I felt coerced. So there is a lot of that, and there is a lot of biases, which is why
Exactly.
this research is important.
Yes. And that when you're unsure of yourself or you don't have a lot of confidence in that moment, you haven't healed through any of your trauma,
Mm-hmm.
it's very easily, to be manipulated or coerced or convinced to be able to do something. But like said, if you don't have that self-determination, that ability to say, I have a little autonomy in this and someone actually supporting me for the confidence to be able to do the change, it's very difficult. It's very difficult to succeed. So that's that. My research has been on stigma reduction in healthcare settings, particularly in how to promote self-determination, this concept of hope in a recovery, and this use of shared decision making. That's what I've mostly been researching over the last decade, because until we get into these very like deep constructs, it's not going to be like this formula and then everything's going to be okay, right?
Yeah.
All right. I'm not saying play devil's advocate,
No,
but
play
a little
devils.
healthy debate here.
I love
Let's
debates.
go.
Bring it on.
I
got my gloves. You got yours?
Oh,
I
yeah.
agree with what you're saying. I do think, and let's use the girl that said, if I wouldn't have been on methadone, I wouldn't be here right now.
Right.
I don't, and again, I don't know her specific situation, just based off of what you shared. To me, there's so many different factors that play into her making the decision to go on methadone, because I am a fan. I agree with what you're saying. Obviously, first line of defense is have them buy in to the recovery process. What I have a hard time with, though, sometimes is if I were to pull, maybe not anybody that we have here right now, but I don't know, Joey, that's been shooting fentanyl for a couple of years. And I sit down with Joey and I give him options of, hey, you can go on Suboxone, you can go on methadone, you can do abstinence-based treatment.
Mm-hmm.
Which one do you want to do? Chances are, again, depending on where he's at in his recovery, he's probably going to say, well, I want to go on Suboxone or I want to go on methadone. Now, me as the professional knows, okay, he's 23 years old. He hasn't been using, IV fentanyl for all that long. He hasn't gotten to experience, say, a program like ours.
Mm-hmm.
Maybe he's been in psych wards and stuff. His parents maybe flushed him into psych wards and state-run facilities and stuff like that. So he's never really gotten the opportunity to experience what a true abstinence-based quality program can look like.
Mm-hmm.
So of course he's going to go to what is comfortable for him.
Mm-hmm.
I'm going to go on subs.
Mm-hmm.
That's going to keep me alive. And we see this so often. You're 23. And you're about to embark on a Suboxone maintenance journey that could potentially be never ending. I know somebody right now in particular, a woman
Mm-hmm.
that is on Suboxone. She has been on Suboxone now for maybe, I don't know, 6 months.
Mm-hmm.
Limited opiate use. I mean, she does have a history of opiate use disorder. But she chose to go on Suboxone after having a tough run with kratom.
Mm-hmm.
But there's no end game.
Mm-hmm.
And we all know sitting here that once you get down to that last little, 2 milligrams, 1 milligram of Suboxone, you're as sick as ever.
Mm-hmm.
And so you just stay on this perpetual again. So I guess my not debate or my question would be, is it in my head, it's a case by case type thing.
Mm-hmm.
Are you guys tracking?
I am. And I see where it comes from, yes, but there's just so many factors. I'll throw this out there, and going back to what you brought up about the coercion part, I hold the opinion that Suboxone, methadone has its place. I will say, through my experience on the professional side, that it has been inappropriately used in more cases than appropriately used. For instance, I believe in looking at the history of somebody, how long have they been on opioids. I just so happen to know the case that you were talking about. For instance, I'm with you on your story because with this young lady, they told me what she was using as far as pills, and the Suboxone is stronger than the pills she was even taking.
Mm-hmm.
So essentially, she stepped up higher in the addiction scale, if you will, in my and physical dependence. That was inappropriate, in my opinion. So it really is case by case, but also like if you now I'll touch on my personal experience. For me, it had to do with hopelessness. It really did. Like, if you sat me down and presented what you said, where it's like, Ben, you can do abstinence based, you can do methadone or Suboxone. That was me at one point. I was in that spot, and I would go back to the coercion part. I was coerced, if you will, encouraged to do methadone at the time. Was that the right thing? I'll never know if that was or not at that time. But what I did know is that if my life could just get just a little bit better,
Yes.
it was better than what I was living. I don't think I had that full hope that, like, yes, I can be abstinent. Yes, I can do this. But we also need help. I could have used some help identifying that, yes, I was capable of being abstinent, because actually I went through a detox, got completely detoxed off of everything. I was actually in detox for 28 days in a hospital in Minnesota, and then got out. First thing I did, my mom drove me to the methadone clinic. I stood a chance that day to be abstinent. I actually remember walking in that methadone clinic, and they go to give me that first dose, and I knew in the back of my head, I was having this inner dialogue like, this is another opioid. I'm consciously doing this. I feel good right now. I've been I'm fully detoxed. I'm not sick. And I knew they started me on 30 milligrams. That first one, I was like, this is kind of the beginning of jumping back into my dependence, at least my dependence on this stuff. And it's tough.
It is. You talked about kind of the stabilization.
Mm-hmm.
If you've been using for an extended amount of time, your brain needs to heal. What is your environment like? Is your environment still the same? Are you still going into the same environment that causes psychological harm, distress, emotional angst, right? Have you learned coping skills? Do you have hope at this point? And in the back of your mind, And in the back of everybody else's mind, you might have a reoccurrence of use.
Mm-hmm.
And I say that it's okay, right? And we're going to learn from these mistakes. But everybody else around, we want to try to prevent you from doing that. So evidence-based research says that you're more likely to not have a reoccurrence of use if you're on medication for opioid use disorder, right? But I go back to, again, what is your self-determination? What do you want? What do you think? And really, like you said, the assessment, what's your environment? What's your history? What's your background? Because we all want to run the Boston Marathon. Okay, I want to run the Boston Marathon. It's going to take me months and months and months of training and mental aptitude and dedication for when the gun goes off that I can complete the 26.2 miles successfully. But it's not fair to say, okay, yep, jump in the race, go do it. Within the first mile, I'll jump out, right?
Yeah.
Yeah, I definitely would. I'd make like the first 0.25, be like, I'm done.
I'm done.
That makes sense. I think there's right and wrong. There's so many factors that play into it. I think the environmental one is probably one of the most strongest. If you're in an abusive household, if you are in a very poor, I guess, neighborhood where drugs are just I understand all that. But
I wish there, I haven't looked, and maybe I need to specifically look, but I have a feeling no one's actually researched this, and I can only speak to what we see here at Rock. On average, I'll throw out a number. We do between 105 and 115 clients a year. Most of our clients,
which is not a lot.
No, most of our clients say 90 to 120 days. That overturns 4 times, so we generally run a census of like 20 to 25, if you will. But with that being said, one thing that I don't think is being captured as a data point is how many people are coming, and I see, Tom, you see this all the time, how many people are coming to Rock where they literally tell us Suboxone is now their drug of choice. Mm-hmm. So it's like, I don't think that data point is being touched on, because actually in the state of Florida, they just passed a law, some legislation, where every treatment center is now mandated to accept clients on Suboxone and methadone. Suboxone in particular, methadone, I'm not sure. I would assume it falls under the same category.
Yes, it does.
But I also don't think that's fair and realistic to say, I have nothing against there being programs that specialize in people on Suboxone, but then how do I tell the client downstairs who's sitting next to a guy on Suboxone, and I'll call it what it is, as an opiate addict, I can spot somebody on Suboxone. I can see it on them. I've got that sixth sense that, I can recognize. If my drug of choice, one of them is Suboxone, I'm sitting next to a guy on Suboxone that appears like he's on Suboxone, I get euphoric recall looking at him. That's not fair. Mm-hmm. And I think however that legislation decided to be passed, I personally don't agree with it. I'm not saying there shouldn't be MAT-specific programs, but specifically telling treatment centers you have to treat everybody, because at the end of the day, I also don't want to pretend like we're masters at all trades. Mm-hmm. Here at Rock, we specialize in abstinence. Mm-hmm. It's what we are good at.
Right.
Yet you're going to make me go outside what we're really good at and try and help everybody. Mm-hmm. That's not even the best service for the client, if that makes sense. I don't like that they lumped all that together.
Right.
And threw it together.
My understanding is that you accept any client or patient regardless if they're on medication or not, and then not demand that they taper immediately. And it really was targeted actually at sober living homes.
Yeah.
Because what happens is most individuals now, they have a medication for opioid use disorder, right? And then they don't have a place to stay.
Yeah.
So that really, I haven't actually heard that legislation with treatment centers. When I was, speaking to with the district attorney's office, that really influential in that was more in the sober living homes.
Yeah. I there's, oh man, you said biases like a few times, and this is one that I definitely have one.
Right.
And what the right thing or the wrong thing to do is, I don't know. But in my mind, it's, if I got a sober living home filled with 15 guys that aren't, they're, okay, they're on their SSRIs and their, blood pressure medications. Okay. But to be told, hey, if somebody calls, says, I need a sober living bed. Oh, and by the way, I'm on 8 milligrams of Suboxone and I have to let them come in. Like, to me, that just seems like, hey, I get it. And this is where my bias comes in. Like, it's not my fault. And it's not the other 15 guys that are in this home fault that you're on Suboxone maintenance. I want you to be able to come in, but it's putting 15 other people at risk for the one. And again, I don't know what the right answer is other than outside of, maybe the state or somebody, I don't know, opens up mat housing and but mat housing has to be like our sober living. It's hands off. They're working. They got sponsors. They're going to meetings. They're sponsoring guys. They're paying their bills. They're doing the deal. You get a house full of people on Suboxone. I mean, I don't know. Who knows? Because are they capable?
See, I work with so many women that are on Suboxone and have, very high functioning.
Yeah. Well, see, this is why we're glad you're here.
This is why we're having this discussion. Because so for instance, one of the things that came to mind for me, we had one of our credentialing bodies come through and they asked us, like, in the sober houses, they were doing the walkthrough, where do you lock up your Suboxone? And in my mind, like, if we have to lock up a narcotic, and then the clients that aren't on are saying, wait, why is this stuff being locked up and distributed? It's lumping everyone together. And again, like, I'm a believer in allowing, just to call it what it is, the market decipher the need, and then somebody will open it. Like, if there's a shortage of mat houses, somebody out there is going to come along and say, we take all the mat people. You know what I'm saying? But to just kind of come through and with the wand, everybody's going to specialize in it. It makes it tough. And again, it's part of my journey. So I'm not bashing it.
Right.
But I don't necessarily agree with the way that the legislation went through.
I think you both have personal experience.
Yeah.
You're running a treatment program that's been really successful. And like you said, we all have implicit biases, but I think it's understanding, is it that I know the right way and this is the only way that you can be successful? Or is it allowing a human being to say, this is where I am right now, and this is what I need right now, and supporting them in that?
Yeah.
Because you're 1 year, 5 year, 10 years ahead. It's not fair to expect them to run the Boston Marathon without any training. And it's different now. The fentanyl, the carfentanil.
Yeah.
It's different.
Well, what has been, and I have no idea if this was the direction you thought this was going to go in.
Yeah,
but,
we have no idea. It's organic.
Oh, your light just died, but oh well. You said you have many, so you primarily women, and a lot of them high functioning on medically assisted treatment. What's that look like with some of the women that you work with? Like, in what capacities are you working with them, and what are some of the things that you've seen? I mean, honestly, success stories of Suboxone, because again, my implicit bias is I don't see many of them.
Right.
But maybe you can change my mind here.
Sure. So when I was still at Women Infants Hospital in Providence, I was on call for psychiatric emergencies on Saturday, and the top neonatologist said of a baby that's withdrawing, mom's been using illicit Suboxone, so purchasing it on the street, throughout the entire pregnancy, and dad didn't know anything about it. So, can you come and fix this, right? I mean, that's what the clinical social worker does in these situations. So I went and I asked if we could speak, the partner, mom, dad, get away from the baby. The baby was really not comfortable. And it was a very stressful situation. At that point, like, dad wanted to punch the wall. Imagine you're the father, you don't know anything about this.
Mm-hmm.
Your infant is not doing well. You feel betrayed. It's a lot of emotions. And the mom was just looking down at the floor, shoulders shrugged, no eye contact, not talking to me, and the dad's just pacing. And I just went back to my research was about how internal stigma and external stigma can really inhibit someone from asking for help. The shame is so huge. I mean, pregnant women that use are the most stigmatized group in our society.
Yeah.
That they are just hiding. And so I just sat down next to her and I said, "Were you too ashamed to ask for help?" And immediately, like, her shoulders went back. She I looked and, like, the tears started coming down her face. And the father of the baby starts walking over, comes right in front of me, big guy, 6'3", muscular like you both, and said, "Do you mean she didn't do this on purpose?" And I said, "That's exactly what I mean. She didn't do this on purpose," right? Like, separating the opioid use disorder from the human, and that he loves this woman. And he, like, immediately sat down next to her, put his arm around her and said, "We're going to figure this out." So instead of the infant being removed from their custody, she went into a hospital and got on medication for opioid use disorder, Suboxone, through a prescription,
Mm-hmm.
and was able to be stabilized and to be cared for and to receive the help. And this family stayed together as a result. Now, if she didn't have the partner and she wasn't white and educated, I think all the advocating that I was doing may not have been successful, because there is other factors here it's called intersectionality of race and socioeconomic status and education and housing. She had, those resources that maybe some other women don't have. But up to 70% of removals in the state of Florida are due to opioid use disorder or other substances, and infants are taken away. And you miss this incredible opportunity. And for this initial stabilization period, Tom, if somebody's been using fentanyl or carfentanil, they need to be stabilized. They need to heal their brain. They need to feel safe until they can start working, because their environment is chaos. I mean, there might be violence, there might be prostitution, there might be, right? There's so many other factors. And if they're under the care of a physician, then at least they're connected to someone, right? And now it can be office-based. So I've published a lot, like, okay, a regular physician, office-based care, where they don't have to go to a clinic. They don't have to go to this. But and I'll tell you one other quick story. There was 2 women in my first study that I published on that actually had support for their self-determination and support for shared decision-making. One was a nurse that supported the patient in the hospital that I worked at. Another one was in Maine. She was in rural Maine, and she was on methadone, and she had read the random control trial that demonstrated that Suboxone is better than methadone for the neonate. So she told the physician that that's what she wanted to do. Her OB-GYN's like, "Okay, we're going to find someone." It took them about a month to find a provider. She drove an hour one way, and the person only accepted self-pay, not even insurance. But because of that, she not only kept her infant, but she went on to get her GED. And she attributed it to the OB-GYN that supported her self-determination,
Mm-hmm.
supported what she wanted, So do you see what the answer is? It's actually not methadone, Suboxone, tapering. It's providing hope and support for what that individual wants so that they can start feeling human again. Right? And then that's the bridge to healing and recovery.
Yeah. I mean, both those situations. Question for you.
Mm-hmm.
Who's following up with these women?
So in the position that I was at, I was only in that immediate birthing and postpartum period, right? So the woman that actually went and was transferred right to the psychiatric hospital, they'll follow her and they'll make sure. And it's like your typical hospitalization and then a step down, whether that's intensive outpatient or residential. But it was a Butler, it's Brown University based. They're not going to just, discharge a patient. I'm a little biased with, Massachusetts and Rhode Island have excellent healthcare systems. And so she was definitely in good care, but her environment was good, right? Because her partner was supporting her and the family was staying together. So again, that goes back to the Suboxone prescribed isn't the answer. What are the environments that we're setting up for someone to have success?
It's having a broad highway with a lot of different exits.
Mm-hmm.
I agree with that wholeheartedly. I think I would, in that situation with that young lady, I would say, okay, like, but what's the plan?
Mm-hmm.
You know what I'm saying? Like, in talking to the partner, okay, you're supportive of this, which is great. Wife, you have a supportive partner. You guys have this new child, but we also have to have at least guardrails.
Mm-hmm.
What does this look like a year from now, 2 years from now? Stuff like that. Because
I agree with that.
Yeah.
But again, we just have to be so careful that the plan isn't my plan.
Right.
Right?
Yeah.
That I'm reflective and say, okay, I know what's best, and this is going to be your 1-year plan. This is going to be your 5 plan, because I don't walk in your shoes, and I don't know what your strengths are.
Yeah.
The individualized plan that you were talking about. They don't want to use much more than I don't want them to use.
Yeah.
That they want to be healthy. Just that's why you threw out the methadone. You were at the point that it wasn't. This isn't okay. I'll never forget a dad in the same hospital. This was like 10 years ago. All tattooed. Big muscular guy, and his wife was using opioids during the pregnancy. He had stopped cold turkey heroin, because this was a while ago before prescription opioids. Cold turkey's like the methadone. It was just a chain to my ankle, and he was going on and on and on and on to me about his story. And it was successful and it was wonderful. But he was also imposing his journey and his story on his partner.
Yeah.
And that can be coercive or manipulative, even unbeknownst to him, because he wants what's best for his partner and his infant. But you're not going to run the Boston Marathon unless I want to run the Boston Marathon and I have a plan that I know is going to work for me to be able to run the 26.2 miles.
Well, that goes back to what I was talking about too. Like, I'm not a huge fan of like black and white legislation where, like, for instance, and they teach us, through, you have to go through the Florida Certification Board, take the exam, all that stuff. And one of the things that you learn in school is to be aware of your biases.
Yes.
And know who you can and can't treat.
Right.
That's why I'm not a big fan of like the black and white legislation. Like, you could say, for instance, I'll use an extreme example. Because I've heard this one very often, some clinicians refuse to work with sexual predators.
Mm-hmm.
Yet, are you going to say you have to take every single sexual predator and treat them in your private practice? It's kind of like, you got to make sure that these people are matched with the people that also believe and don't have that bias.
Right.
Is kind of where it gets kind of rocky for me. But I'm with you from a principle level on like 1,000% everything that you said. And I'll get vulnerable on this too. Like, I'm very careful for myself of speaking in black and whites, because I've been on the side of this where, part of my story, and I talk about this when I speak at a 12-step meeting, where when Whitney got pregnant with our son Weston, I remember saying to myself, thank God now I can be sober because I have a child on the way, and it's the best reason in the world to be sober. Yet I was still unable to stop.
Mm-hmm.
And
I'm so glad that you shared that.
And go ahead, sorry.
That's really powerful, because you can beat yourself up, right, for being not a good father or not a good mother, because even though you were still you were powerless in that moment.
Oh, it's so hard to explain to people. You mentioned earlier that, some of the, I think in a roundabout way you were saying this, if you didn't say it directly, but some of the best parents that I know are in recovery. Terrible parents in active addiction, but I'll honestly sit here and tell you that people with long-term sobriety are better parents than quote unquote normies.
Yes.
Like, really, I have a lot of personal friends out there that I'm like, these are the best parents around.
Yes.
They blow normie parents out of the water.
Right.
Because of the work that they've done on themselves.
Right.
But I'll throw this out there too, like part of my personal experience. I know through some of the stuff that we talked about before we hit record, for instance, when Whitney got pregnant with Weston, inability to stop. At that point in time when she first got pregnant, she was doing mostly just oxys, and she went to treatment voluntarily. I think she was in her first trimester, but they actually tapered her with Oxycontin, which, she did relapse. I'll throw it out there now. I was getting high the whole time. I actually showed up to her family weekend, blasted out of my mind as the support. I was shooting heroin and like showing up to be the supportive father,
right,
which wasn't good, and I'm not saying she relapsed because of me, but I was getting high the whole time while she was in treatment, getting help. She came out. I was getting high. She went back into the home with me.
Right.
She had a relapse, and we were using oxys and heroin throughout the rest of her pregnancy. She actually stopped 10 days before she gave birth to Weston. She cold turkeyed it because she knew we were going to get him taken away if she
it's pretty
came up
common.
positive.
But you wonder, and there's no what ifs, but would she have had the reoccurrence of use if the environment was different and she was on medication for opioid use disorder, even if it's just short term, right?
Probably not.
Yeah, you never know, and that's.
But you're right,
and that's why I'm like bringing up my personal experience with like, I still, every time I talk about it, I still talk about it with shame, because I was playing a major part in providing these opiates while, she's 9 months pregnant, looking like she's going to burst. And I just remember sitting there with her, and we're like, tomorrow's the day we're quitting. Tomorrow morning, this is the last day. We had that conversation every single day and just couldn't stop. And when she was able to stop 10 days before giving birth, it was literally, I want to say within 36 hours of us getting home from the hospital, the drug dealer was at the house. It only took us a couple weeks for the police with her family to walk Weston out our front door. And she actually, I was going somewhere with this too. She actually ended up in a program at that point in Minnesota where she got to have Weston with her. And I haven't seen too many programs duplicate. I know there's Wayside House here. I mean, I'm sure they're out there. They're just so hard.
Pregnancy.
Oh, just pregnancy. You said that.
Yeah. So what I know from my research and other researchers, having the mother and the infant as a dyad has the best outcomes for long-term recovery.
What's that mean?
That you keep the mom and baby together.
Okay, that's what I thought.
That you look as a two.
Yeah.
Not as a one.
Yeah.
As soon as you separate and polarize, then we've taken their reason away.
Yeah.
Their number one motivation. And it's actually very detrimental for the infant.
Sure.
So infant mental health is very important. And what the infant knows for 9 months is the mother's voice and sometimes the dad's voice, the smells, the gait of the walk. And if you remove that, then it's detrimental to the infant's mental health. So not only does it help the mother's mental health and recovery, but also the infant. So that's why we have to have more programs as a dyad. And the highest incident of maternal mortality death of women postpartum is opioid overdoses. And the reason why is because we've removed the number one sense of motivation and hope, and how they cope is opioids. And if they're not on medication for opioid use disorder,
Yeah.
you have another death statistic then, right? So we need more programs.
Where I'm on board with, I'm not a doctor, but I could just assume through kind of common sense. Like, for instance, if you have a young lady that's pregnant, and the chances that she's gonna shoot fentanyl or heroin or Oxycontin, where there's highs and then sick, and then high and then sick, and then high and withdrawal, versus putting them on Suboxone, where yes, having an opioid in your body is probably not the healthiest thing for the baby, but I can 1,000% tell you what's worse is that up and down of putting a needle in your arm.
Yes, and then you have the risk of hepatitis.
Yep.
All these other, so that's what
Putting
all
yourself
the evidence
in the environments,
violent
to achieve,
situations. Think about all that. So there's no study that doesn't. All studies say medication for opioid disorder is the recommended standard of care for pregnancy and early postpartum.
I don't know that I necessarily disagree with that, Tom.
I'm gonna sit here and say I feel like you've changed my mind a little bit with women, pregnant women. But in my defense,
yes,
I've never
experienced,
yeah,
and it's my goal wasn't here to change your mind.
Yeah,
Tom.
no, I
It's
know.
just that for all of us to understand what are our implicit biases, reflect on that, and what are the reasons for my thinking, and then just have new perspective and understanding.
Yeah.
Right? There isn't any more difficult and intense trauma than your infant being removed. I mean, you still, you're raising your son and you still have shame, and it's what? Decades later, decade later.
I do. I
right?
still, I'll admittedly say this weekend, it literally cropped up in my mind that there's this part of me still trying to make up for that. Because like I was questioning myself this weekend, like, am I doing enough for my kids? School just started. I'm not, maybe I'm not spending enough time. Weston's playing football after school, so he's at school, and I don't hardly see him as much as I was seeing him during the summer. And now I'm like, but that shame is still there.
And so that's what it is. It's working. Okay, what is my shame? And I'm sure you talk about this in Alcoholics Anonymous. I've never gone through the program, but like forgiving yourself, right? Forgiving yourself, letting yourself be cleansed. Whether it's higher power, God, but how important that is of hearing the shame, understanding it, and then forgiving yourself for it, right? Because you were not in a place that you are now, right? You've grown and you understand, and you don't have an opioid use disorder active right now. And allowing yourself to just forgive yourself, and you're a good dad. You're a good dad.
Appreciate that.
It's a living amends, Ben. You're doing a living amends.
No, that's a funny thing about it too, is one of the things you were saying earlier with going back to, like, I was saying some recovered people tend to be the best parents. Like, people look at Tom and I, they would have no idea we're in recovery. What they see today, 2 guys that work out, 2 guys that run a business, 2 guys
Success.
I mean, Tom's taking his kids to Disney World once a month, like we were talking about. Literally,
which is
like,
impressive because I have to prepare myself 12 months to go to Disney World.
But like, Tom in fatherhood is killing it, in my opinion.
Of course.
And like, but so people would never guess that at one point in time,
but see, that's
we were
what's so
completely
wonderful.
powerless.
Right, but that's so wonderful. You are incredible fathers, right? What if there wasn't somebody that didn't believe in you when you were still actively using?
I'll say this. If I didn't have the people in my life then, and I've actually thanked my parents, and I've also thanked Whitney's mom. Her dad had passed away before we met, but I thanked her mom, and I said, thank you for being there for Weston when we couldn't.
Right.
Which, I'll be honest with you, when we lost custody of Weston, I was furious with her mom.
I'm sure.
Because, like, I'm in my active addiction thinking, like, she's not letting me see my kid. And that, but at the end of the day, now that I'm sober, I realize she stepped in, and because you were talking about the home environment, all that stuff.
Right.
Like, thank God, and I'm grateful that I had people in my life that were willing to take the responsibility of my son when I wasn't able to do it myself. And I think about those situations and those parents who didn't have
Correct.
a Deb in their life, who didn't have my mom and dad in their life. And maybe it's some woman whose parents are deceased, or maybe they're alcoholics and drug addicts themselves and not supportive, whatever the case is. And some young lady loses custody of her kid, but has zero family support.
And you know how many months you have to be able to get your life together?
Not a lot, I'm assuming.
Less than 12 months.
That's like what the court expects, so to speak?
That's housing. That's a job.
Yeah.
That's recovery. And you're all by yourself. And you rely on public transportation.
Going back to that, we were talking earlier, and I just want to briefly touch on this too. One of the things that you said was that pregnant mothers and active addiction,
highly stigmatized.
Well, that, and generally they lack resources big time.
Correct.
No money, no insurance. So that's like the people that need the most help sounds to me like no resource. I'll be honest with you, like from what I understand, like licensing standards, like the reason we don't take pregnant women here is because liability.
Mm-hmm.
To call it what it is, we don't want to be liable for the life of an infant if the mother decides to use overdoses and dies, like takes off property or.
Well, we have, not to say we don't take them. We have
in the past.
It once, and this is a recommendation from our compliance officer.
Mm-hmm.
Once they reach the 3rd trimester, then they have to, or I can't even remember exactly.
I can't remember what the details were.
But yeah, we try and, Yeah,
and usually 3rd trimester is the safest. Think about the mother of Weston.
Yeah.
Most women do not use the end of their pregnancy, even if they had, a severe opioid use disorder, because they don't want their infants taken away.
Right.
Right. So it's actually safer, but it's to your point. What do I do? There's nobody that's going to help me. People that are treatment providers don't want to treat a pregnant woman, and then OB-GYNs don't want to take care of them prenatally because they have a substance use disorder. So they literally don't have treatment and they don't have prenatal care.
Yeah.
It's a very difficult scenario.
Yeah. And that goes back to, like, how do you legislate that? Because what I see would be like, oh, we give a treatment center that takes pregnant women complete immunity. But then you're going to have the bad guy that comes in one day and says complete immunity and take advantage of the situation and whatever it is and somehow try to make money off of it. Like, there's always bad players that come along and ruin a good thing. And that's where it gets so hard to write legislation and laws that, it drives me crazy. It really does.
Absolutely. A lot of it is policy.
I think it's where priorities lie for legislators and lobbyists and stuff like that. I mean, if I can just speak freely, I don't think they care about pregnant women.
Mm-hmm.
I think it's financially driven. Most policies, procedures, legislature, all that stuff is financially driven.
Absolutely.
And that's the unfortunate part of this.
We should touch on that because we talked about this before hitting record too. I mentioned when I was in Minnesota, like I was born and raised down here. A lot of the listeners know that, but I went up to Minnesota for 4 years, stayed in active addiction up there. It wasn't until I came back to Florida that I got sober. But Minnesota had called it was called a Rule 25, and there was an actual fund within each county. Each county had X amount of dollars, and they utilized the private treatment centers and essentially paid for treatment. rather than trying to build new buildings and new programs. They utilize the resources that were already there.
Right.
Which I think is a really smart
Excellent.
model because, it's not just good for people seeking help, but it's also good for small businesses, the economy, all the other stuff. There's
Yes.
people that, like yourself, for instance, I'm just throwing, I would guess that if you had the opportunity to open up a treatment center or run one that specialized in pregnant women, you would. But it comes back to like, they don't have the resources. How are we supposed to keep the doors open? But if the opportunity's there, somebody that cares about that niche, they're going to come along and say, I'll help them,
Right.
you know?
Right. I mean, it has dividends, right, to society. If we keep the mother and infant together, the mother-infant dyad, then you're interrupting these cycles of fractured families,
Yeah.
right? Because the 70% that due to neglect and substances that are removed, it's not the families that have Weston's grandmother available, right? I mean, some of them, but a lot of them don't have the environment and the resources to support. So they just go into the foster care system. And that's very expensive, right? It's very expensive. So if we can reallocate funds into what you were just describing in Minnesota, we would save so much money for Florida.
Why's it got to be so complicated? Why do they have to overcomplicate? I mean, I think between the three of us, we could solve this issue.
Yes.
I don't understand it. And the big factor in all of it, too, is, fatherless households.
Yes, we have to support fathers. There's a big movement in Tallahassee of trying to get more fathers involved and support to fathers. Dr. Adam B., he's amazing. And that's important, too. That's just as important because this usually is both partners are using, right? So we need support for fathers also. But my research and work has been with women primarily because the women are the one that are punished.
Yeah.
The women are the ones that can have custody with alcohol or substance use disorder, mostly substance use disorder, because many, many women use alcohol during their pregnancy and nobody knows.
Right.
And actually, alcohol is much worse for the fetus.
Yes. Yeah.
That's degenerative and irreversible. But that's a whole nother podcast. But the point being is that women are incarcerated. Mothers are incarcerated. Not the fathers. The mothers are punished because they use during the pregnancy. And that goes back to the biases and the stigma, which you're right. We could easily, the three of us, say, okay, we're going to think about this differently. We're going to turn this upside down, that we're going to offer treatment, and we're going to offer support, and we're going to kind of change the environments to create success.
Do you happen to know? I was just thinking about like Florida or maybe Rhode Island, Massachusetts. Do you happen to know like what the number at any given time on average is of women that are pregnant and in active addiction?
Oh, it's so high. The National Survey of Drug Use just actually presented all the findings. They do it every year. But like in the last decade, the number of substance exposed infants have raised 310%. So it's very, very high. And some of it's detected and some of it isn't.
I was going to ask that. It went up 310%. Is that just that we're better at collecting data now, and it's always been there?
No, it's because of the prescription opioid.
Okay, so it's
crisis
we're still
with the
suffering.
turn of the century. So it went from prescription opioids, and then that got too expensive illicitly, and then it went to heroin, and then it went to the fentanyl, and then it went to the carfentanil. So that's why it's gone up so high. And of that 310% increase, of all the infants with neonatal abstinence syndrome, it's like 80% are on Medicaid. So we have to step back and say, okay, what is the socioeconomics behind this? Are we saying that only individuals in lower socioeconomic status that don't have private health insurance use opioids? Of course not, right? But we're managing this group. I'll be a little bit provocative and say maybe even surveying a certain group and, controlling a certain group. of lower socioeconomic status or ethnicity or race.
I feel like I could talk on this for hours, but
I know
this goes. We're an hour and 20 into this.
Yeah, that's usually our episodes are what, 45 minutes, an
Yeah.
hour.
Yeah,
Yeah, we could just.
I
keep
could
going.
keep talking,
And we didn't
talking.
even cover. You have to come back on. So let's set that.
I have
up
like
before
10
you
more things
leave.
I want to say
yeah.
too, like little bullet points.
I want to talk to you, not today, but are you local? I'm assuming.
Yeah. So I was telling Ben, are we offline now?
No.
Okay.
No, well, you tell us after, but you got to come back on soon because I want to dive into the family stuff that you were talking about. Supportive,
I love that.
Yeah, because we didn't talk about it yet, but we started a family reconnect program.
You were telling me, Ben, when I was here last.
Yeah,
which is so great.
Yeah, it's all online. It's all women right now, mothers
great.
and spouses and stuff like that. But definitely want to hear your perspective on what you're doing for families, and then potentially have you come on as a speaker.
That'd be great.
On a Tuesday night at 6:00.
Yeah. Anything to support rock recovery. I mean, so right now I'm the executive director at Stoked on Life. And one of the visions I have is having a family component.
Yeah.
And be able to have families embrace the curriculum and go through it as a family and heal on the beach, because it goes back to I'm a little more vulnerable, I'm a little more open, and I'm listening maybe a little bit more. And we've had, a few success cases with some family work, and I really feel like it's such a need to support families and to be able to do this aquatic therapy. So I'm so glad you're doing that.
Yeah.
At Rock Recovery, it's so important.
Well, do you go by Dr. Heather? I feel like we should be calling you Dr. Heather.
So I tease. I say, I only have my oldest son, Ben, call me Dr. Howard.
Nice.
Dr. Howard?
Yeah, Dr. Howard. But I just tease. No, I'm. You can call me Heather.
Okay. Well, Heather, we appreciate you coming on, and we're gonna set it up to have you come back on here soon. So,
Great.
Ben, any final thoughts?
No, I enjoyed the conversation. I like it when it gets me thinking and.
Yeah.
Are we doing this right? What do we do?
Or what are some gaps that we could fill potentially?
Yeah, exactly.
Yeah. So
thank you both.
Yeah. All right. That is it for this episode of Real Recovery Talk. Thank you for tuning in. In the end, if you have any comments, questions, or concerns, you can always reach us. info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. That is it. We will see y'all later.